Balancing benefits and harms.
This is the first of the 8 ethically relevant considerations. This is the paramount traditional ethical principle in the practice of clinical medicine, and here we're balancing ethical considerations of beneficence and non-maleficence. What needs to happen here is that any outcome that should result should try as much as possible to maximize the benefits for a patient and minimize the amount of harms.
Disclosure, informed consent, and shared decision-making.
As many of you listening to this podcast know, bioethics and legal thought in the past 30 years have challenged whether clinicians should have the unilateral authority to determine what medical treatment is in the best interest of patients. The ethical principle here is respect for patient autonomy, the right of adult, competent patients to determine for themselves whether they will accept treatment is recognized in the legal and ethical doctrine of informed consent. In order to actually exercise voluntary consent, patients need at least to receive truthful disclosure from their clinicians concerning what their condition is, the benefits and risks of alternative treatments, what their prognosis is, both with and without treatments. Informed consent requires ongoing dialogue between clinicians and patients. This is known as shared decision-making.
Norms of family life.
As we all know, familial relationships give rise to moral responsibilities. And depending on the particular case at hand, it's up to ethics consultants and clinicians to determine the appropriateness and how strong the norms of family life should be relevant to a particular case. The closeness of family members, their particular histories with each other, whether there are any dysfunctional relationships within the family. All of these things are important when discussing and considering the norms of family life.
Relationships between clinicians and their patients.
Obviously, a relationship that a clinician has with a patient will be very important, especially when delving into the murky waters about ethical issues. Therefore, the trust the patient has in and the trustworthiness of clinicians can be very important. If the patient does not trust his or her clinician, communication can break down. And if the clinician is viewed as not trustworthy at the end, ethics consultants might need to be involved in a case of that nature.
Professional integrity of clinicians.
This principle plays an important role in determining whether treatment or care requested by patients or their surrogates is ethically appropriate. Patients are free to refuse treatment. That's an acknowledged ethical and legal right. However, the converse is not true. Patients are not entitled to receive whatever treatment they demand. Clinicians have no responsibility to provide treatments that they consider medically inappropriate, but these determinations must be supported by appropriate evidence.
Cost effectiveness and allocation.
Both of these considerations are increasingly at stake in questions of the distribution of medical resources and efforts to contain the spiraling costs of healthcare. The ethical principle that is relevant here is justice. Many of us are aware that managed care and other cost containment efforts are the occasion for many ethical conflicts between patients, clinicians, and now especially third-party payers. We need to have equitable procedures that must be applied in order to make ethically acceptable decisions about the allocation of medical care. The clinician is the patient's main advocate for access to medically indicated health care and entitlements to coverage under private or public insurance plans. Therefore, they shouldn't be afraid to pick up the phone or ask one of their other staff members to be the advocate for the patient and get what is required for the patient.
Culture and religion.
We should realize that for some cultures and some religions, the ability of the patient to be self-determining, the exercise of autonomy that we have in the United States, and truthful disclosure may be somewhat foreign to the cultural practices of some patients. What we need to do here is ensure that clinicians apply sensitivity and tact, and perhaps religious or cultural consultation along with ethics consultation. The worst thing you can do is just make the bland assumption that because someone is represented by a particular culture or religion, they will hold the same belief as is typical with that religion. What is best to do is what I call offering the truth to the patient. What this means is that you offer the patient, at the beginning of your advanced care planning process, before you have any information to deliver to the patient, You ask them if they would like to know the results of tests. Who would be the person to communicate with? The patient here is worthy of respect, and by asking them what they would want to do, they should be able to tell you, yes, I represent myself in these matters, don't talk to my family, or they will tell you that they would rather have you deal with certain members of their family so that you can move forward with an ethical decision.
Considerations of power.
Differences in power shape or underline ethical problems in the clinical setting and deserve special attention in furthering the principle of respect for persons and their autonomy. It is almost always the case that clinicians are in a greater position of power in relation to their patients and their family members. Shared decision-making requires sharing power. The major vehicle of sharing this power is conversation. This conversation has to evolve between the clinician and the patient's family. Shared power involves recognizing the patient's or the surrogate's moral standing and right to participate in decisions. And here, of course, one of the important things to remember is clinicians should be mindful of what type of language they use to communicate with patients. They should use language that is understandable to their patients and not use medical jargon or obfuscate in any way.
Clinician virtues.
There are several types of virtues that clinicians should possess in order to deal with ethical issues, as well as to provide basic good care. There are 9 of them. The first is technical competence. We want our clinicians to be technically competent, to participate in continual lifelong learning. The second is objectivity and detachment. We want our clinicians to be objective and somewhat detached, but what we don't want them to be is cold or emotionally unavailable to patients. The third is caring. Caring is a complex perceptive and emotive disposition to relate to persons with the aim of helping them satisfy their needs. This is opposed, of course, to objectivity and detachment. You may ask how these two things can work together. This is a very difficult balancing act, and clinicians with a great deal of experience have the ability to be both objective in gathering and diagnosing information, being somewhat detached in their relationship with the patient so they don't become immersed in the patient's issues, but they also display a very caring and compassionate disposition to their patients. Number 4 is clinical benevolence. This means that all clinicians strive to benefit their patients and do what is required for them. One of the things you need to do is to have subordination of self-interest in order to be a virtuous clinician. That means that you disclose to your patient when a referral you make will influence your bottom line. You need to say, I am here for the patient, and I am going to subordinate all of my interests while I am caring for you. The 6th thing is reflective intelligence. We like our clinicians to have the ability to reflect on the clinical literature, to reflect on their own practice, and to reflect on their own patients and their patients' experiences. That leads into the 7th clinical virtue, humility, which is recognizing that you don't know everything, that you may need to get consultations, that you may need to consult the clinical literature, and that you don't know everything in the world and that you're not, quote, playing God. Practical wisdom is the ability to access the clinical literature when you know that there is something you may not exactly know. It's basically the wisdom that's required when dealing with ethical issues. Number 9 is courage. All clinicians require a certain amount of courage, either in dealing with managed care organizations, in dealing with complicated issues with their patients, when trying to stand up to other clinicians who may in fact disagree with them. And this is a very particular strong virtue for the nursing profession. The nursing profession has traditionally been subordinated to the physician profession, and nurses now require the kind of courage to stand up and demand that they have equal standing when it comes to ethical issues in the clinical care of their patients.